Sickle cell disease is an inherited blood disorder affecting red blood cells, causing them to have difficulty passing through small blood vessels. This can lead to significant pain and other serious problems. It is the most common genetic blood disorder in the country. Although most prevalent in African Americans, sickle cell disease can affect people from any racial or ethnic group. Newborn screening is a systematic effort to identify at birth conditions that can affect a child's long-term health or survival. Early detection, diagnosis, intervention can prevent death or disability, enable children to reach their full potential. Each year, nearly 70,000 babies in Minnesota are routinely screened using a few drops of blood from the newborn's heel for certain genetic, endocrine, and metabolic disorders. They are also tested for hearing loss and congenital heart disease prior to discharge from a hospital. Sickle cell disease is one of the conditions screened by the newborn screening program. We're going to talk about sickle cell and newborn screening on today's program. But most importantly, we're going to talk about how the newborn screening program changed its protocols and procedures when it discovered that those procedures were not giving everyone the greatest opportunity to be healthy. It's a great story about how to advance health equity in a very practical way and how important it is to listen to the needs of the community being served. Please stay tuned.
Welcome to A Public Health Journal, a program that explores the public health issues facing our society today and tomorrow. The host of our show is Dr. Ed Ehlinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health, the Hennepin County Human Services and Public Health Department, and the Minnesota Public Health Association, all working together towards the goal of healthy people living and thriving in healthy communities.
Welcome to A Public Health Journal. Today we're going to talk about newborn screening, particularly screening for sickle cell disease, and how Minnesota's newborn screening program changed its protocols to better meet the needs of the community at greatest risk for sickle cell disease. Joining me in this conversation is Rae Blaylark, founder and executive director of the Sickle Cell Foundation of Minnesota, and Maggie Dreon, a geneticist in the Public Health Lab at the Minnesota Department of Health. Welcome to both of you.
Thank you.
And I'm anticipating a good conversation about a really important topic, sickle cell disease and newborn screening and how they come together. And so let's start, first of all, Maggie, talking about the newborn screening program.
Sure.
Explain what it is.
Yeah, so newborn screening is a test that we do on all babies shortly after they're born. And the goal is to look for different disorders that have some sort of treatment or cure so that we can get those children plugged into those services before any sort of damage occurs from the disorder that they might have.
So how does the screening occur and where does it occur?
Yeah, most often it's done in the hospital, but we know that out-of-hospital births are happening more frequently as well. So really, whoever is caring for that child when they're born is responsible to make sure that the test is done. There's three parts to it. So there's a heel prick that's done between 24 and 48 hours where we collect a few drops of blood. And that's where the majority of testing is done, is on those drops of blood. But we also look for heart defects and we look for loss of hearing in the range where speech is heard as well.
All right, and how long has this program been around?
Minnesota started screening in 1965, so we recently had our 50th anniversary. And at that point we were testing for one disorder, and now we test for over 50. So it's continued to grow throughout the years as science really was able to progress and offer more treatments and more testing options.
So as science progresses and we do test, find out ways to identify things that we can actually treat, then we add those to the program?
Yep, exactly. So we have an advisory committee that will help to vet through whether a condition should be added or not, and then we bring that to you so that we can decide if a condition's eligible.
And is this program unique to Minnesota, or does every state have newborn screening programs?
Every state has their own program. They're all run a little bit differently, so depending upon where you're born will determine which tests you were, or which conditions you were screened for or not. So there's a federal law that every state has to have a program, but ours is unique to itself. I think it's probably one of the more robust programs out there because we do a really good job of following up on all of these children and making sure everyone gets their screen done.
All right. So when you have a positive screen, what happens? Does the health department contact the baby's parents, or how does that work?
Yeah. So once the lab identifies a positive result, they send that over to the genetic counselors like myself, and our job is to find that child's primary care clinic to make sure that they have the information, they know what was found, they know what they need to do next, and then we rely on the relationship that the primary care provider has established with that family to make sure that they pass that information along and get that family into the system.
All right, so you really work with the clinicians that are dealing with the family.
Absolutely, Yep.
Good. And I understand sickle cell disease is one of those things that we've been screening for.
Correct. So we started screening for sickle cell disease in 1988. So it's been a while now since we've been looking at that. And the goal of sickle cell is to look for, of our testing for sickle cell is to look for those who have disease. But when we do that testing, we find children who have disease, we find children who have trait, where they carry that genetic change, and then we find people who have normal blood or normal hemoglobin. And we can see all of that with the way the test is done.
Okay, good. Well, that takes us to sickle cell.
Yes.
Right. Tell us a little bit about sickle cell disease. What is it, and why is it an important issue?
Yeah, sickle cell disease is a disease of the red blood cells. So in a normal healthy person, your red blood cells live probably about 120 days. Whereas someone with sickle cell disease, because of the abnormality of the red blood cell, their red cells are only going to live about 10 to 20 days. That change in and of itself can bring a lot of damage to the cells. It can bring damage to the tissues and even the organs, and it causes a great deal of pain. And because of that, children are also more susceptible to different infections and things that can change the course of their life. And so there's a huge danger in having the disease, and we want people to know that they have it.
All right. We've got a couple of slides here just graphically show,
Yes.
you know, the one with an umbrella that shows sickle cell
Yes.
disease. You know, there's a whole range of sickle. Tell us.
Absolutely.
It's not just one thing.
That's exactly right. Sickle cell disease, if you think about it as the umbrella term for the disorder, and then you have specific types of sickle cell disease. The one thing that they have in common is the hemoglobin S, and that is the sickle hemoglobin. Now, when that's combined with other variants of hemoglobin, then you have different variants of the sickle cell disease. Now, the most common is SS, where they're getting a sickle hemoglobin gene from each parent. But if you get one sickle hemoglobin from one parent and you get another variant from another parent, you'll have different variations. SS being the worst, and then you have SC, you have sickle beta thal, or sickle beta thalassemia, and then you have several other variants that are not as common but are still present.
Okay. And then we have the next slide that actually shows you talking about the fact that the cells are a little different than normal cells.
Yes.
And it's actually the sickle cell is because they're formed in the shape of a sickle as opposed to a little globule like normal is there.
Absolutely.
Tell us a little bit about this slide.
Yeah, so in sickle cell disease, what happens is those red blood cells are not able to carry oxygen, and that deoxygenization causes a change in the shape of the cell. And that shape often looks like a C or an S, and it gets very sticky and it's very rigid. And those cells together, when they get clogged up, is what's called a vaso-occlusive crisis. That's what causes the pain, but that's also what causes the damage that's occurring. So if that's happening in various places of the body, sometimes there are external signs that it's happening, but then there's internal signs. Sometimes there's no sign at all, and that's where end organ damage and things like that can occur. So the danger really is the fact that these red blood cells are not able to carry oxygen to the organs and the tissues that need that nourishment from the oxygen. It's also what causes them to die very quickly, and that turnover of red blood cells, that the body cannot keep up with the loss of the red cells and the capacity to make more cells to replace them.
So that's what causes the anemia. When the blood cells, anemia is this low blood count.
That's exactly right.
And as those cells disappear, they're not replaced as rapidly as possible.
Absolutely, absolutely.
So who can get sickle cell anemia?
Well, sickle cell disease is not just a disease of African Americans or people from African descent, but sickle cell disease is really a worldwide disease. It is found most prevalently in areas where malaria was existent. It's often referred to as nature's way of kind of preserving a people, if you want to think of it that way. There would be pockets of survivors when malaria hit these areas, and what they found over time, and obviously it took generations and generations and a lot of scientific effort to see that what the common theme in these pockets of survivors was an abnormality in their red blood cells, where they did not have the disease, but they carried a single trait for sickle cell. And that allowed them to survive some of the worst times of malaria. Whereas malaria, when you're infected, it lives inside of the red blood cell and it replicates itself until that red cell explodes, and then the malaria takes over the body. Well, if your red blood cell doesn't live long enough to do that, then it's not going to have the same devastating effect. So it's really quite profound the way that we make the relationship between malaria, sickle cell trait, and sickle cell disease. Now, the flip side of that is you have pockets of survivors with sickle cell trait and not necessarily then understanding understanding the genetics behind those people then having children, and then the chances of having a child with the disease.
All right, well, that's what I want to get into now in terms of identifying the sickle cell trait and how you then deal with that. But first, we need to take a little break. So we'll be back right after this video.
Trayvon is a normal 12-year-old kid. He loves to play outside. He's a family kid, though. He loves family. If there's an opportunity to hang out with Grandpa, that's what he wants to do.
Very good, Trey.
He also belongs to a hip-hop dance group at church. And he enjoys doing that. He's part of a group, he's part of something. He loves having the performances, getting to know other kids getting to know him. He enjoys life. He enjoys just taking part of life, not letting life pass him by.
But for Trayvon, life is not always normal. For him, a normal childhood is repeatedly interrupted by the ongoing obstacles and struggles of sickle cell disease. His red blood cells change and harden, creating anemia, and with it, pain, sickness, and a number of serious health concerns.
Normal childbirth, had no reason to think that there would be anything that would be medically wrong. At the time, I didn't know what sickle cell disease was. I think that for some time I was kind of in a state of shock, because I wasn't able to necessarily process that. And yet I wanted my child, my one and only child, to have as normal of a life as possible. We've had good days and we've had bad days. This disease there are moments of this disease that are very unpredictable. He can be doing very well one day and the next day wake up in severe pain.
When you have a crisis, it hurts. Your body just aches, like every place that you can think of, your body just aches right there. Your hands, your feet, your head, your shoulders, your neck, your eyes, everything just starts aching and you get very sick.
Through blood transfusions, the depleted red cells are replenished, restoring him to health and the vibrant energy of his youth.
My son's life depends on others. I play my role, his father plays his role, but life comes from others. That's what kept him alive on multiple occasions, and that's what will continue to keep him alive. Donated blood is life. There is no price on life. Donated blood is life. Your donations have saved his life. There aren't enough thank yous in the world to show our appreciation, but we say thank you.
Thank you.
Welcome back. We're talking about sickle cell disease and newborn screening with Rae Blaylark, Executive Director of the Sickle Cell Foundation, and Maggie Dreon, a geneticist with the Minnesota Department of Health. Trey, how is he doing?
Trey's doing well, He is on treatment for his sickle cell disease, and he has a wonderful team of physicians. He's getting older and getting healthier and getting wiser and understands sickle cell. He definitely learns a lot from me kind of tagging him along in my journey with sickle cell, but that was the goal. The goal when I had him was I knew that I had to advocate for him until he was able to advocate for himself. So I had to be the learner and the teacher.
Yeah, that's the role of parents.
Yes, it is.
Good. Well, now I want to get into the real meat of this conversation. Maggie, I understand that the health department made some significant changes on how it deals with sickle cell. Tell us a little bit about the story of what you used to do and what made you change to what you're doing today.
Yeah. So when it comes to a kid who has disease, we have a very robust process, kind of like I explained earlier, where we really engage the primary care clinics to make sure that the children know that and that they're informed about that and they get the medical care that's necessary. We, about 2.5 years ago, joined a work group that was taking a look at some Midwestern states and what they were doing as far as the trait notification to families. These kids we don't mean to find trait results. It's an accident with how the testing is done, basically. So they don't have disease, they're healthy, but we were finding this information, and we were finding this information on about 1,200 babies a year. And before we took a hard look at this, we really weren't doing much to make sure that families knew this. It was a very passive process where we would send the final report that we generate after the newborn screen is done. We send that back to the hospitals, and we hope that families would eventually get that information. And there's a lot of steps that have to happen between, the hospital and where the family actually ends up getting their care. So we knew there were gaps. And we joined this group of other states to say, well, what are you guys doing as far as trait notification? And we took a look, and we were really the only one that hadn't taken the time to come up with a process to make sure that families knew this information. And that was kind of our aha moment, is in all of the different markers of what we felt were valuable opportunities to make sure that families were getting this, we were missing them, and we needed to do something about it.
So Rae, why is this important to notify parents that they have trait? First of all, explain again what the trait is, so people understand what we're really talking about.
So when we were talking about the sickle cell disease and the umbrella term and how you get, one gene from each parent, and if you get 2 abnormal genes, particularly the sickle genes, you'll have sickle cell disease. But if you only get 1 abnormal hemoglobin gene, then you'll only be a carrier or have trait status, and that's what the trait means. And there are typically no medical challenges with having the trait. Most people understand trait as, if you're going to have a baby and whether they're going to have blue eyes or brown eyes, or if they're going to have light hair or dark hair, or different things like that. But so it's kind of a silent. It lives silently. But when you have a trait for a genetic disease, the important piece to understand as the parent of a child who has a trait, or as a person who has the trait like myself, is that means you have the highest risk of having future children who have the disease if you have children with someone else with that same trait or a non-complementary trait.
All right, so why is it important for the health department to notify the providers, the clinicians, that somebody has trait?
Yeah, well, I'll use myself as an example. I learned that I had the trait in high school, but there was no education around what that meant. So the next meaningful conversation that I had about having the trait was when, at 2 weeks old, when my son when I was being told that we got a positive newborn screen for sickle cell disease. At that point, it was only then that I was able to put those pieces together. No one had put those pieces together for me, nor did I have the opportunity to be able to have a conversation with someone who could help to educate me. And so it's really important that people who have the trait understand, prior to making decisions about future family planning and understanding what their risks are going into those childbearing ages. It's a conversation that has to happen, whether you're having children or not. It's a matter of knowing what's in your genes, as I like to say, and everyone, whether it's high blood pressure, regardless to what it is, should know if there is health risks that run in your family. Sickle cell trait can be considered it's something that should be talked about within families, and we have to be informed first through the medical process to do that.
All right, and I want to talk a little bit about that process, but we need to take another little break, and then we'll talk about how we're really functioning now and what we're hoping to succeed with this new approach. So we'll be back right after this message.
I'm Jenny Garth, and as a mother of 3, I know kids worry about a lot of things. Getting enough food to eat shouldn't be one of them. But here in America, that is a real worry for 1 in 5 children. This is unacceptable, and something Feeding America is working to solve. Through a nationwide network of food banks, Feeding America serves virtually every community in the United States, including yours. See how you can help your community. Visit feedingamerica.org. Together, we can solve hunger. Together, we're Feeding America.
Welcome back. We're talking about sickle cell disease with Rae Blaylark from the Sickle Cell Foundation and Maggie Dreon from the Minnesota Department of Health. Rae, were you aware that the health department was not notifying parents of sickle cell or individuals of sickle cell trait within their babies?
You know, no, I actually was not. It was only very recently, in the last few years, that I came to that realization. And a lot of it was parents coming to me and saying, you know, I didn't even know I could have a child with the disease. No one ever told me that I carried this characteristic or this trait. Or people who would tell me, if no one told me I had it, then of course I'm going to assume that I don't. And so that's the other difficult part, is that, you know, in our community, if you're not informed that you carry something, then it feels like it should be safe to assume that you didn't.
Right. And Maggie, how did you interface with the community, particularly the African American community, where it's the most prevalent? But,
yep. Yeah. So once we learned about this problem and kind of saw that there was an issue that needed to be addressed, we actually went out and did focus groups with the community. And I think that's where this project became really unique, in that we took the opportunity to step back and say, okay, I'm an expert, as in I'm a genetic counselor, but I'm not of that community. I don't know what they want. And so we went and we actively engaged and we asked them. We said, this is what we find. This is what's been happening. Talk to me about what you'd like to see happen, so that we could really understand the impacted community's preferences. So we had 5 focus groups with African Americans and individuals who identify as West African, all parents, and we talked about it to figure out how would you want this information to get back to you. And I think some of the points that Rae made, you know, were said multiple times. The fact that no news is generally considered to be good news. So I had no idea that this existed, and every person that was part of our focus group said, I want to know this information. I should know this information. It's about my family. And we want to have an engaged process to make sure that that's happening.
So how difficult was it to change the process? And what about the providers, the clinicians who have to share this information with their patients, with the families they're dealing with?
Yeah, I mean, I think the hardest part was figuring out that there was a problem and where to start and figuring out how to fix it. Once we had the conversations, it became very clear what the right path forward was. We've developed a process where we're actually directly communicating with families for the first time ever. We're sending a letter to the families about this. And then we're also engaging with the primary care providers to make sure that they get the results, so that both of those things have happened. The providers have the information, the families have the information, and that's the catalyst for a conversation. We've seen big changes. Before this change, we kind of sent a survey out to providers to say, how often are you talking about trait results? And about 26% of the time, providers said that they were talking about trait results with the families. After this change, that number's jumped up to 60%. So there's been a significant change. We obviously can do more, and I think a lot of that is on provider education, getting them comfortable to talk about sickle cell, getting them comfortable to engage in that type of a conversation, or to find the resources that are out there.
Right. Do the primary care docs know how to talk about sickle cell trait?
You know, I think that's can be challenging. I think that the reality is that some families aren't sure how to talk about it, and because of the lack of conversation that has occurred in the past, it feels like a new conversation, and yet we have enough information out there medically for providers to be able to educate themselves and educate families in the best ways. Part of it also is educating in a way that families can understand. And so if there's follow-up conversations, or if they would like to see a geneticist or need to see a geneticist, those kind of referrals are very important as well, so that families feel like their questions are being answered. It's not just a fly-by-night conversation, oh, by the way. We want families to really understand the impact and the implications. And you also have to keep in mind that most of these conversations are happening while that child is still a newborn. Once that child hits childbearing age, there's more conversation that needs to happen, so that now we are certain that that information is being passed along to the child who is at risk of having children with the disease.
Because this is really a 2-generational thing. It's the parent who has the baby, but then the baby himself.
Yes.
or herself who has the trait
Yep.
is going to
Yes.
have to make some reproductive health decisions down the
Absolutely.
road. So how have things changed at the health department in the last minute that we've got? How does this change how we do our work?
Yeah, I mean, I think it's changed because it's changed how we engage with the community. And through our engagement with working with Rae and the community of interest, we've really identified that there's a number of things that are going on with sickle cell, and we can make this a bigger conversation about how do we fix all of the other things. I think trait was our inroad into really addressing some of the disparities that exist with sickle cell, and now we need to go further and really encourage public health to take a specific look at what's going on with this disease and this disorder, and how do we best help, and what is our role in that.
And Rae, what do you see as the next steps?
Yeah, the next step is really continuing to engage the community, where the community feels like that there is attention being paid to a disease that still does not have a cure. Since 1905, there still is only one therapeutic medication to treat sickle cell disease. And unfortunately, it wasn't even designed for sickle cell. It was found by accident. And so there's still some concerns over that, and there's still more work that needs to be done, and there's still more funding that needs to be done. But the education piece is critical, and that's on both sides of the table. Education to families, of course, but education to providers as well. We really have a deficit in providers that are specialists in sickle cell disease, not just hematology, but sickle cell particular.
Right. Good. Well, thank you both, and thanks for the collaboration that you had to move this forward, because this is an important issue, both from the public health side and certainly from the family side.
Absolutely.
So thank you for your work.
Thank you.
Thank you.
I'll be back with a closing comment right after this message.
Every time I hear the alarm bell go off in school, I think it's an air raid. A lot of houses in our neighborhood have been destroyed. I like to close my ears and sing songs whenever the bombs come close. I'm worried our new neighbors won't like us. But I know it's all gonna be worth it. I just want my family to be safe. But these are not my words. These are not my words. These are not my words.
In 1742, Thomas Gray wrote a poem entitled Ode on a Distant Prospect of Eton College. In this poem, he states, "To each his sufferings all are men condemned alike to groan. Yet why should they know their fate? Since sorrow never comes too late, and happiness too swiftly flies, thought would destroy their paradise. No more, where ignorance is bliss, 'tis folly to be wise." For many years, some healthcare providers often chose not to share disheartening information with parents, agreeing with Gray's perspective that when ignorance is bliss, 'tis folly to be wise. But as we learn more about what creates health and what is needed to advance health equity, we are moving farther and farther away from this antiquated aphorism. Today's discussion is a case in point. Public health's role is to help assure the conditions which all people can be healthy. Having every baby screened at birth for treatable conditions that would interfere with a baby's healthy development is one of those conditions that helps create health. Health equity is another one of those conditions. Health equity means that all people have the opportunity to realize their health potential, the highest level of health possible for that person, without limits imposed by structural inequities. Having access to information and knowledge is essential for making personal life decisions, is a critical component of health equity. That's why sharing information about sickle cell trait with parents of an affected newborn is vital in advancing health equity in Minnesota. It allows people to make informed life choices that could have profound health consequences for their children. In the case of sickle cell trait, ignorance is not bliss. And not sharing that information is not only disrespectful, but a form of structural inequity. From what we've learned from the work on sickle cell trait, it is obvious that we need to include an equity perspective with all of our data sharing activities, because ignorance is not bliss. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.